So today we have a leading ACL injury researcher with us. Dr. Stephanie Filbay has debunked some of the major misconceptions around non-operative recovery, including disproving suggestions that choosing rehab alone over surgery results in increases in osteoarthritis and meniscal damage, not to mention her recent groundbreaking paper on ACL healing. But before we get into that, I want to take you back to an 18-year-old Steph who's just ruptured her ACL and wondered what advice you'd give her.
All right. So, as sounds like you're aware, I did first rupture my ACL when I was 18. I remember the advice I was given when I first went to see a surgeon. It was the first thing he asked was, do I want to return to sport? And I said, of course I do. And he said, well, you don't have to have surgery. If you're happy to run in straight lines for the rest of your life, you could consider just rehab. And I said, well, no, of course. I want the surgery. I want to go back to sport. So if I could go back in time, I would, hold myself up at that point and wish that I had someone that sat down with me and spoke about both treatment options and the pros and cons of each, the likely outcomes and the evidence that was, available at the time. Because, I think what would have made sense to me, I believe, even back then, is trying rehab first with the acknowledgement that, hey, my knee mightn't become stable and I mightn't get the function that I want, which was a really high level of function, and then I might go and have surgery. But at least I would know whether, I could recover naturally from that injury before going down the surgical path.
Yeah.
Because it was quite terrifying. Like, as a just turned 18-year-old, I was fairly afraid of surgery. I didn't want to go and actually have the incisions and get cut open and go into hospital, but I thought that I had to, really. So, yeah.
Yeah. And that, I presume that's what's motivated you into the field you're in now, in terms of not only making that information more accessible, but also clarifying some of that information as well. A lot of your research has challenged the assumptions that were previously out there.
Well, I think, so my PhD initially focused on quality of life after ACL injury and after ACL surgery, and looking at ways to improve long-term quality of life, because it is poor. So to reduce the burden that the injury is having on people's life. It didn't really set out to, to focus on non-surgical management. But what sort of motivated me more recently is what I'm seeing in terms of misinformation online on surgical websites that are educating surgeons, or on hospital websites educating patients, as well as research articles that aren't supported by the evidence themselves and recommendations. So it's that mismatch, being aware of the literature and the best evidence that we have available, and the fact that that doesn't align with what's being told to patients and recommendations that are out there online as well. So it's that, inaccuracy that's kind of motivating me to communicate and to do research in this field at the moment.
Yeah, that must be incredibly frustrating for you, from both the perspective you've done a lot of research to disprove or certainly challenge a lot of these narratives, but also as a patient yourself. It must be very frustrating when you see that out there, in some really mainstream medical organizations putting out information that isn't substantiated.
Yeah, absolutely. We recently did a Australia-wide survey of patients who'd had ACL injury and undergone treatment, and as well we looked at clinicians. But we wanted to know what those patients, it was just under 800 people, had been told by healthcare professionals about their management options. And what we found was that most people received advice that wasn't reflected by the evidence. And the common misconceptions that are still out there. So 90% of patients had been told by a surgeon that if they want to go back to sport, that they should have surgery, that's the best treatment option. And 60% of physios also told that to patients.
Oh, wow.
Yeah, and it's just not reflected in the evidence. It shows no difference in return to sport rates. Yeah. There's no evidence to suggest you're at increased risk of re-injuring your knee. So this common belief that's really persisted, that if you want to go back to sport, you have to have surgery, it really influences people's treatment decisions, because people that tear the ACL are typically young sport participants, and that's what they care most about. So,
well, we're both sat here as people who have disproved that. I guess I know you're playing a pivoting sport now, and so am I. I've returned to playing sport, so evidence alone, but I know that's not enough. What do you kind of feel like needs to change out there to really influence that narrative change? Because obviously you work very closely in the medical industry, but for that message and information to get to patients when they're making that difficult decision, is there something that can be controlled there, or the influence is just too strong?
Yeah, so I think it would need to be multifaceted. So first of all, it's educating the clinicians, because these are the people who patients see and who advise them about treatment options. So it's educating surgeons, it's educating physios, sports docs and GPs. The next is starting to change public perception, because, especially where I live in Australia, everyone thinks if you tear your ACL, you have surgery. And one of the reasons for that is because if we're watching professional sport, Aussie rules football in Australia or rugby, someone does their ACL, the first thing the commentators say is, they've broken their ACL, they're off for surgery to fix it. And then if you're a recreational, sport participant and you do your ACL, you think, well, if my sports heroes are having surgery, then I want to have surgery. It must be the best treatment approach. So the way that it's portrayed in the media and in relation to professional sport can really impact societal views around it as well. And then we need to educate patients. So in order to do that, we need, first of all, to have accurate information that they can access online. At the moment, most of the information isn't reflected on evidence. So we did actually set out to do this, and we've developed a free online patient decision aid.
Oh, amazing.
So the aim of that tool was exactly that, to provide a balanced overview of both surgical and non-surgical treatment for ACL injury, and communicating the harms, potential risks of each, the benefits of each, and the likely outcomes depending on which treatment approach you go down. And we wanted to do that so that people could make an informed decision about the treatment option that works best for them. So you can find that one. It's on www.aclinjurytreatment.com. And that we intend to be ongoingly updated. So as new evidence becomes available, we'll incorporate that into the actual website itself, so it's reflecting the current evidence. And so, it had quite a thorough development, which was based on large surveys, qualitative, so interview studies, and then a review of the highest level of evidence available in the field that went on to inform that content. And we hope to communicate that in a way that people can understand, not too technical. And so hopefully resources like that and other resources out there can start to educate patients as well about their treatment options.
Yeah, that's incredible. I feel like that's dare I say, that's what I was missing during my journey of figuring out what the right things to do was to try and find some objective guidance and know who to trust. I want to talk about the elite sports world stuff, but I feel like it's a remiss of me not to hone in quickly on, I think, the paper that has really sent shockwaves through the medical industry that you led on regarding the cross bracing protocol, which showed a 90% plus healing rate to ACL ruptures, which were previously deemed in many quarters unhealable. The impact has been pretty big. Like, we don't see much, certainly not change in this space recently. But how's the reaction been like for you? Were you surprised were you expecting it to be bigger and that suddenly people are transforming the way that they operate, or have you been kind of pleased that some people and certain areas are starting to listen now?
Yeah, I think the interest, but also the acceptability around this new idea that actually not only can the ACL heal, but appears to heal at a much higher rate than we thought possible. So the first paper where we looked at data in the Canoon trial which was published just before the second paper, that showed that at least 1 in 3 people had ACL healing on a 2-year MRI when managed with rehabilitation. So this was with no bracing at all. So that was really surprising. And then in that study, we found that those with healing on MRI reported better outcomes at 2 years, not only compared to those without healing, but they also reported better outcomes compared to those who'd had ACL surgery. So that was really interesting and a surprising finding. And that's sort of led into this bracing protocol. But what we have seen, we've seen a lot of media interest. We've seen a lot of patients reaching out. I've received over 200 emails now from people all around the world saying, I found this paper, I've torn my ACL, can you help? I don't want to have surgery. I want to try this bracing treatment. And a lot of clinicians reaching out as well, physios, sports doctors, and some surgeons who've seen the research and are really interested and want to get involved. So even before this research, which was published in this year, both of these studies, we already knew that management with rehabilitation alone and considering surgery down the track compared to early reconstructive surgery has similar outcomes, so that surgery has no additional benefit over initial rehab. So we've known that for some time based on clinical trials. But it really hasn't changed practice in a lot of parts of the world. In Australia, the vast majority of people are still having surgery. I think the way that we used to present that, where we talk about being able to cope without an ACL if you have rehab, it's not a very attractive option for patients. I don't want to have to cope without one. I want to go get it fixed with surgery, is how a lot of people would see it. But I think people can understand, oh, hang on, the ligament can actually reconnect and potentially heal. That makes more sense. It's a more viable and attractive alternative to surgery, I think, for people, knowing that there's that potential there. We are seeing a lot more buy-in and desire to access this treatment than we've seen with other non-surgical treatments.
Yeah, I think Mick Hughes put it really well when he said non-operative is kind of suitable for people who are comfortable in the grey rather than the black and white, whereas what this is giving us is a definitive situation for people where they go, yeah, my ACL's healed, I'm good to go again. Whereas for people functioning with a ruptured ACL and no idea whether it has healed because a repeat MRI isn't available to people unless they want to pay up for it, is ambiguous, and you never, I guess, you're kind of operating in a bit more unknown than you would anyway. But I mean, you walk onto a football pitch or any type of sporting arena, and there's an unknown there anyway. So that's the way I've kind of framed it. So for people that don't achieve that healing, or you do have a repeat MRI and you haven't had healing, we're not saying, well, it'd be great to get your perspective on whether at that stage you go, well, maybe you should have surgery, or if you're coping fine. And I don't really like the term conservative, because it does feel like, you're not doing as much anymore. Where really, for me, my understanding is the rehab is pushing your body to a new level of strength and capability to function without the ACL intact. So still your advice, go back to 18-year-old Steph, she's had a repeat MRI and she's not had healing. Would you say, well, if your body's still doing fine, still keep going and only have surgery if your knee then gives away?
Yeah, so absolutely. I would be in tune and listen to my knee in terms of its function. And what we mean by function, the most important thing there is stability. So is that knee stable? Because we don't want to cause extra damage to the knee. We don't want to sort of go on and damage the meniscus or the cartilage. So we don't want to be just putting up with a wobbly, unstable knee that's giving way. Absolutely not. So the first sign that this knee is not going to have a successful recovery, that's when I suggest it's a really good idea to consider surgery and go and see a surgeon. Not 5 years later where the knee's given way 10 times and you've caused further damage to the knee. This was the criteria that we used historically when we thought that ACLs didn't heal. So we knew that at least 50% of people would not need surgery if they try rehabilitation and start with rehab. And one of the key indications for an unsuccessful outcome was the knee giving way or being unstable. But now that we've got this research showing that the ACL can heal or resume continuous fibres, so the fibres can rejoin as seen on MRI, is it that actually those who have this unstable knee don't have healing of the ACL, and that's why they didn't regain a degree of knee stability? We don't know, but, my intuition suggests that healing may have, maybe the missing piece of the puzzle to determine why some people do really well and others really don't do well when they're treated with rehabilitation.
With that instability, is that testing? I mean, obviously, once someone gets, if they haven't got knee stability, we try and rehab that. Is it a case that you get your quad strength back to within above 90% of what it was previously, and then and obviously the supporting muscles around it, and at that point, if you're still experiencing stability, that's when you consider surgery? Because I guess the risk is that people suffer a knee injury and then they experience significant kind of muscle loss, that yes, their knee's going to feel unstable, but that might be because the muscular structure around it's not really doing its job, and they could still rehab it to the point where regardless of healing or not, that they can get back to the stage of it being a back to usable knee and functioning well without risking that additional damage that might come from trying to do certain activities without having the muscular integrity restored.
Yeah, so it's having sufficient function to do what it is you want to do. So for people that say don't play cutting, jumping and pivoting sports and don't really have any desire to, it's possible that your knee might feel unstable if you went and played a game of soccer, but that's not something you want to do, and that actually your function's sufficient to do the kinds of activities that you want to do. So in those cases, as long as you're avoiding any activities that may cause your knee to give way, then that can be safe as well. But you're right. So earlier on, the characterization of having an ACL rupture is that your knee will be unstable. But what we're suggesting is that with time, your knee, if you're going to have an ideal outcome, will regain stability.
Yeah.
And it may take, at least 3 months. So it doesn't happen overnight in 5 days. And there's other things that might feel like your knee gives way, like when your knee buckles because you have a bit of swelling in the knee. It can cause the quads don't function properly when there's a bit of a fusion in the knee, and then you might be going up and down a stair and your knee sort of buckles beneath you. That's not what we're talking about. What we're talking about is typically rotational instability, where it grossly gives way and causes you to often fall to the ground.
Yep.
So that's why you need a really good physiotherapist, and hopefully they're supervising you and progressing you through achieving different goals of rehab. And then they should know that despite progressing in your strength and your function and having sufficient strength, your knee's still not stable. It's not mechanically stable. So hopefully a good physio could make that differentiation. And before you go to sport, hopefully they're doing quite extensive return to sport testing.
Yeah.
So you really should have tried all the sorts of tasks that you'll be doing during sport in a safer environment first to ensure your knee and your strength and your function's ready and can perform under those conditions before you go and actually play a competitive match, for example.
Yeah, I guess I'm thinking, and my question probably wasn't very directly worded, but the appropriate time to make that decision, because time is an important thing for a lot of people, particularly in, we're talking about the importance to lead from the elite athletes and their decision-making processes are what going to trickle down often. And do they want to spend 3 months trying something without exposing the knee to any sort of structural risks, and then find when they do return to training that their knee isn't stable, and then they've not wasted, because we know the value of doing rehab before surgery. But just think about that conviction in decision making processes and the importance for athletes.
Yeah, I mean, I think 3 months is a good minimum window, because we used to think, before we considered healing, we used to suggest trying rehab for at least 3 months before making a decision.
Yeah.
But now that we are looking at healing on MRI, 3 months is early enough to see if there will be a degree of healing. So we can already see the ligament fibers have reconnected by 3 months. So the ligament doesn't look completely normal by 3 months. It's still undergoing, a healing process at that point in time, but it seems to be early enough to see if there'll be any healing or no healing.
Yep.
So that 3 months time point,
that's as early as you'd put it in, because people obviously, people are getting surgery almost the next day in instances, because they think, well, the quicker I get surgery, the quicker I can get that graft in, the quicker that graft starts to build its strength and stability, and the quicker that's going to be ready to return to sport. Because for an elite athlete, right, they're going to be able to do their rehab in 6 to 9 months, because they're going to be in the gym pretty much every day, unlike us average people who would benefit maybe more from that 3 month head start. I'm just trying to think from really from that elite perspective, what's really, because what I hear from people, and playing devil's advocate, is they say, oh well, that's a wasted 3 months that they could have been post-operative and healing. And those are the questions I guess people are going to ask when considering this.
Yeah, so a few things I'd consider there. So I agree. One of the main downsides to non-surgical rehab is the uncertainty in knowing, will I end up having surgery or will I have a successful outcome? And then that can, if you go on to have surgery, that could delay it by, let's say, 3 months or even longer, right? Could delay your total recovery time. However, if you are successful, your rehab time can be shorter, and you can return to sport faster. So it's a pro and con on each side. It's not a clear-cut decision there. On the other hand, we need to acknowledge that only 55% of people return to competitive sport after surgery.
Yep.
A lot of people have poor long-term outcomes. And then of most concern is the risk of graft rupture. We know that that's highest in young people and young people returning to sport. So if you go on to re-tear your graft after surgery, you are in a really poor position. You're likely to have very poor outcomes, including osteoarthritis, chronic pain, poor quality of life at that point in time. And 90% injure their meniscus and cause further damage to other structures at that point. So I think if you are someone to have a successful recovery with rehab or with the brace, and have healing, you're not then at risk of being in that position of graft rupture, which we really do want to avoid for people.
Yeah.
And in professional athletes, the risk of rupturing grafts is really high. They perform for a shorter duration than their non-ACL injured peers. So they often don't return to have as great a longevity in their sporting careers after surgery. So I don't know. I don't think it's as clear cut as we think. People often think of surgery as a sure thing or a fix, but it isn't. And there's additional trauma that's caused to the knee during surgery, which you can avoid if you do have a successful management without surgery. So the main con of non-surgical approach is the unknown as to whether surgery might be recommended for you down the track.
Yep. But
the pro is avoiding surgery potentially, but also time-wise maybe being able to return earlier if you do experience healing because the return to sport guidelines, obviously we need more evidence around returning to sport after natural healing. But we know that the ACL graft still appears to be undergoing ligamentization as far as 2 years after surgery. And so we really don't know the timelines of the ligament healing and remodeling over time, but the graft also needs to do so. It's generally tendon that's put in there. It's not actual ligament tissue.
Yeah, so that can never reach the full strength and size of a ligament, right? So I guess the important message that you're putting out there, which I'm fully aware of as someone who's been through the surgical pathway, is that it's not a silver bullet, and there are a lot of complexities to surgery. So as much as naysayers might pick holes in the non-operative and the healing, or be uncomfortable with any ambiguity, well, you've really got to balance that with the challenges that surgery faces in terms of finding your best pathway for a patient.
Yeah, and it should be the patient's decision, right? So if they say, oh, so I could try rehab for, let's aim for 3 months and then see where my knee's at. And, there's maybe at least a 50% chance that I'll avoid surgery altogether. Some people will be like, I'd love to take that chance. Yeah. I'd love to try that first. And others may be like, no, look, I'd prefer just to go straight for surgery.
Yeah.
So, but people need accurate information so they can make that informed decision themselves, which most people aren't receiving at the moment. So
yeah, I love that simple way of framing it for people. Are you aware of any elite athletes that are currently considering or trying the cross bracing protocol? So that research has come out and it's had a few months to settle. So it'd be interesting to know if there is anyone out there looking at giving it a go.
Yeah, so at the moment there's over 12 elite professional athletes that have undergone the bracing protocol. So that includes things like international rugby players, Olympic judo athletes that had successful heals and returned to sport. So we are going to see that number still to be quite small because they have so many other pressures on them, and it's often not their decision to make. It's often their medical team and their sporting clubs and other people that are often driving these decisions. But in saying that, the majority of people that have undergone the brace are competitive athletes. They're taking part in, Aussie rules or rugby, soccer at a high level, but not professional.
Right.
And there's no reason why professional athletes, if anything, they tend to receive so much rehab support. They can focus on their rehab all day, every day, that it only is likely to improve their outcome with any treatment approach they go down.
Yeah.
But I think it's more going to be certain professional athletes that we see who are asking or demanding certain treatment approaches rather than it coming down through management, for example, because we've had a strong surgical bias in sports medicine for a long time. And it's typical that an athlete gets referred straight for surgery. It could be a foot injury, an ankle injury, shoulder, even spine, knee, and that would be the typical treatment. They go and have orthopedic surgery as quick as they can, so.
Yeah. And because they're exposed to such because they're exposed to such high quality rehab, that's probably got more to do with their successful outcome, right, than which decision they would have made anyway. Like the way I see it, ultimately, the quality of your rehab that you put in has overriding importance than whether you have surgery or not.
Yeah, well, yeah. That's why we really need to understand this role of healing, because it's a little more complex. It's not as simple as healed or not healed. When we say 90% had healing after this brace, what that means is before they had the brace, the ACL was completely torn. So you can see a gap between the two ends of the ACL, completely ruptured. And then after undergoing the brace, that ACL had rejoined. So now the fibers are continuous from where they begin to where they end. But amongst those, so that's 90% that had a continuous ligament at 3 months. But amongst those, more than half were really normal appearance, or it may be slightly thicker still by 3 months than a normal ACL, but normal tightness. And then just under half are slightly thinner, or they could look a little elongated, so a bit longer than usual. So those that had a normal appearance or thicker were doing better than those who were a little bit thinner or elongated at 3 months. So we know that when you get this normal appearance heal, it's definitely a really good thing. But what we don't yet know is when it's a bit longer or it's a bit thinner, how does that compare with an ACL graft? We don't know yet. Do these people have good knee function to return to sport? It seems a little bit more mixed in those people with that heel. Some people function great and others will go on and have surgery. So we're trying to understand now, what elements of healing that we see on MRI strongly relates to the ideal knee function that we're trying to achieve.
Yeah. I listened to one of your podcasts that you recorded talking about the results of that and how you looked into it. And correct me if I'm wrong, but with return to sport rates, the question was up about the time frames and stuff, and you were very cautious saying about we don't want to rush people back, because actually when we saw from the results, I think, was it 4 people re-injured, but they were, and I was like, this is sounds so unlucky, because all 4 of them were from heavy contact injuries, whereas obviously we know particularly any ACL susceptibility is majority injuries are non-contact, so really hard to tell whether they would have, regardless of what their ligament was at that stage, whether it's a healed one, their original ligament, a graft, it's kind of impossible to know whether those injuries would have occurred either way, right?
Yeah, so those 4 people, that was in the in those people that had the thickened but normal appearance, so the more ideal heel.
Yeah.
Yeah, and 2 of them were high-speed accidents, falling off a bike and other unlucky things. And the other 2 had returned to sport earlier than was advised. And it was a rugby tackle or an Aussie rules tackle.
Yep.
So the thing is, 92% of those people had returned to their pre-injury sport by 12 months. So that's a much higher percentage than we see after surgery, which is on average 55%. And the number one risk factor for tearing your graft after surgery is returning to competitive sport.
Yep.
So they are going to be exposed to those same demands, those same situations, the same risks to which their ACL initially ruptured in. So we need to kind of keep that in mind. If the return to sport rate's really high, we are going to see some ACL re-ruptures.
Yep.
But what we really need, we need longer-term data. So there's now been, as of today, this morning, patient number 518 was braced. And so now we're starting to collect the data for a larger number of people. And we'll also start to look at long-term follow-up data so we can understand things like re-rupture rates after undergoing the bracing protocol and in those with ACL healing. But we need to acknowledge that, we don't have the long-term follow-up data yet to get the full picture around healing of ACL with the brace.
Yeah.
Yeah.
Very much focused on, helping patients make the right decision here, and an informed one at least. I wanted to quickly talk to you about kind of the financial driving factors. We've kind of touched on it a little bit there, the incentives that are driving probably lack of progress in change in Australia. We've got one of the highest surgical post ACL rupture rates in the world, whereas other countries, particularly in Scandinavia, they're close to maybe 50%, whereas in Australia I think it's above 90% of people who are having an ACL rupture are going under the knife. On the flip side of that, in terms of what's really going to encourage people to from a high level to change this, I wouldn't say culture, but this approach, is saving that money, right? And that money's not, sometimes it's coming out of the patient's pockets, but often, particularly in the UK, it would be funded by the NHS, a lot of these operations. Has there been any research into if we could reduce those rates of people having surgery, what kind of financial savings that would result on? A lot of governments under financial pressure and strain and struggling to fund health services. Has there been any research on like the benefits that would have if we weren't putting people on the knife potentially unnecessarily? Yeah,
so we're actually designing that study at the moment. So it hasn't run the analysis yet, but hopefully you might see that come out in 2024 in terms of the potential cost savings. The best data we have around the comparison of cost or cost effectiveness is from the 2 clinical trials comparing early reconstruction with initial rehab. And both of them found that surgery was not cost effective compared to initial rehab. So there was, a cost saving for doing rehab first.
Yeah. So no brainer, right? Like, particularly if you are returning, I was kind of cleared for sport after 5 months compared to 9 months or 12 months of physio. From that alone, you're saving money as a patient, and then the surgery costs.
Yeah, but, as an individual patient, so that's like at a societal level that we consider cost savings. But for the individual patient, you've got, I try rehab and it may end up being much lower cost than surgery if I have a successful outcome. But if I go on to have surgery, I'll pay for the surgery, the post-surgical rehab, plus the window of rehab that I do first. So that's sort of the risk is, those physio consults, whether it's once a fortnight for 3 months, potentially, so that additional cost of those consults. So there's a chance that you'll have a saving if you have a good outcome, but if you go on to have surgery, then those costs will add on. So it's still weighing up the pros and cons of that. If you have private health insurance that covers surgery, the cost and out-of-pocket cost is much lower. But if you don't, so in Australia, people typically go onto a public wait list. In Melbourne, where I'm based, some of the hospitals have a wait list for ACL surgery of 18 months long at the moment. And I spoke to a physio working in a regional area, and he said it's 2 to 3 years wait.
Oh, wow.
For an ACL surgery. And these people are receiving nothing typically while on the wait list.
I was going to say, you'd hope at least they'd be using that opportunity to go, well, let's try and rehab you then. Because if the waiting list is that was one of the motivations for me, was hearing there was at least like 4 to 6 weeks of even seeing an orthopedic surgeon. But yeah, crazy that people are waiting that time, but they're not trying, or not being advised, because it's definitely not their fault if they're, facing the narrative of you're not, until you have surgery, you can't do anything but walk in a straight line. But yeah, that's incredible. And from a kind of, a public health perspective, obviously those numbers would add up pretty significantly if they are being funded.
Yeah, so we are planning to randomize controlled trials to evaluate this bracing protocol. So one that we're planning will be in a public setting. So it will capture people that are going onto that wait list and randomizing, half of them to this bracing protocol. And the other half would have their usual care whilst on the wait list. That would be an interesting design because we can compare healing between those two groups.
Yep. Between
a group doing a brace and a group doing essentially nothing or maybe some rehab. But we can also compare surgical rates, assuming that a lot less people would need or go on to have surgery if they do have this bracing treatment early. The other trial we're planning would be in a private sector, and it's comparing ACL reconstruction with the bracing protocol. So I think both those trials are really needed, and they would complement each other in terms of the information that's provided.
Yeah. And I'm trying to think of the right word for this, and you'll definitely know it. But ultimately, is the study that we need a kind of a fake surgery one where people think they've had a reconstruction? Because people report better outcomes, right? Because they think they've had an intervention. It's the same with the placebo effect, right? Is that
exactly? So a placebo surgical trial. That would be like, right? Okay, ethically, exactly. That would be so hard to do, but it would be so important and meaningful if someone could. I mean, I think it would have to be done in Scandinavia or Finland or somewhere where there's a society where altruism is really high in relation to research, and people are happy to enter these placebo trials, and they have done for other surgeries at high rates, because there's a society where, people are happy to put their hand up for studies like this. I think it would be really difficult to do it in Australia or some other places. But the
Not
thing is,
implying
right?
that-
So,
Yeah.
the ideal. Okay, so the ideal placebo ACL reconstruction trial, you'd have one arm that go and have the normal surgery, and then you'd have another arm that has all the same surgical components, except the component that we think actually is contributing to the mechanism of the surgery, which is the graft, right? So what they'd have the incisions, they potentially
Still
even have
drill holes in their bones.
drilling holes in the
wow.
bones, maybe putting screws. Well, but you probably want to leave the actual ruptured ACL there because, so it would be quite complicated and it would still cause a lot of undue trauma to the knee. So it would be ethically very hard to get people to consent to a study like that for that reason.
Yeah.
For less invasive surgeries, it works a bit more easily, like the meniscus placebo trials that have been performed, because let's say you're having your meniscus resected or cut away, then they make the incisions, but they don't touch the meniscus, versus they make the incisions and trim the meniscus away. When you wake up from those surgery, you can't really tell the difference about what's been done in the knee. So that's easier to design in the placebo manner. So that study exists, and they found that those having the real surgery had no additional benefit over the placebo.
Yeah, wow.
And we often find that for a lot of these surgical procedures. So
they did it for tennis elbow, right? Was that one of those that they proved that there was no benefit to having surgery for tennis elbow?
Yeah, and meniscus as well. That's one of the key trials.
Relevant, but
And I think there's a shoulder debridement surgery as well.
Yeah.
There's a few different. They're really hard to do, right? They're really hard to recruit into, to design, but super important and interesting. And so it's just acknowledging that surgery itself has a huge placebo effect, and there's a lot of contextual factors around it, as you can imagine. You know, you're being put to sleep thinking my knee's going to be fixed, and you're woken up thinking it's fixed and it's recovered. That placebo effect. It's not to be underestimated because it's still a real effect. It still can have a real effect on your perceived outcome. It's just that some surgeries may not be working for the reasons that we thought they may be having benefit for a lot of people, if that makes sense.
Yeah, but belief is so huge, right?
Yeah.
I was watching a Louis Theroux documentary. He's reviewing his previous his early series, and he said, I don't believe in God, but I believe in religion, because the power of belief turbocharges human beings to do stuff that they couldn't do otherwise. And it's so true. If you're stood there on a training field and everyone's saying to you, "Oh, shouldn't you've had surgery? Are you okay? Oh, I won't tackle you." You're going to feel weak and vulnerable. Whereas people see you back and you've done what you expected, and they've seen you rehabbing hard for a whole 12 months, and you're back and you're stronger than ever. And you believe that, and your body's going to reflect that in its performance, I imagine.
Absolutely. And we find in multiple studies that one of the main predictors of a surgical outcome is someone's expectation to do well. And that's even the case if that's considered an unrealistic expectation. So they expect to be running a marathon or doing brilliantly after a joint replacement. Those people do better than those that expect a less positive outcome. Yeah. So why is that? Is it belief, or is it also touching on people's personality types in relation to optimism, resilience? These people with, positive expectations, they expect to do well, to bounce back, and they're more likely to do so. Don't know, but yeah, it certainly seems to be an important part of the picture.
Yeah, but makes so important what you're providing in terms of, helping people not just see the other side, but really make a decision with conviction. I want to just finish on one final question. Really appreciate your time and some absolute invaluable insight in there. I know I'd have loved to listen to this when I was going through the decision-making process. But I wanted to get from you a sense of, given the research you've conducted and the stuff you're going through at the moment, if we started by kind of taking a time machine going back to when you're 18 and you rupture ACL, I want to fast forward now and go forward to 10 years in the future, and where you'd like to see the sector sat at based on the evidence that's out there.
Again, it's enabling an informed decision, and to do that, it's providing accurate information about treatment options, and so that would have to come from both online resources, but also the clinicians they see. So we know there's surgeons out there that provide excellent information and a really balanced overview of treatment options. But there's others that are providing unbalanced and non-evidence-based information. And the same applies for physios. We see mixed in terms of what people are doing. So, yeah, in an ideal world, I'd like it to be for patients to receive more accurate information so they can make informed decisions. And it's a little bit tied in with referral pathways and other things, certainly in Australia. For example, if you have to go and see a GP to get imaging or rebated imaging, and then the GPs refer on to a surgeon, and then you're told you need surgery and booked in for surgery before even hearing that non-surgery is an option. So the kind of ways that our healthcare systems are set up and the people that they require you to see and the order in which they require you to see them, it can all impact on the kind of decision we make and information we receive. So, yeah, I'd like to see more of a change, more education of clinicians and public so that more informed decisions can be made about treatment options.